Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and to delve into the challenges and impact each technology has in practice. This is the Medtronic Med-Ed learning experience. The BIS monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Reliance on BIS system alone for intraoperative anesthetic management is not recommended. Medtronic's medical education programs are offered to provide attendees education on the FDA-cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidien LP, a Medtronic company, for the speaking engagement. For this segment of the series, a discussion on anesthesia and the brain, we will discuss the 3 phases of BIS monitoring and how they can potentially provide useful information during anesthesia. To help provide insight into this topic is Dr. Stephen Bader, Chief of Cardiothoracic Anesthesiology at Heritage Valley Health System in Beaver, PA.
We essentially, most clinical, anesthesia people are going to think of the BIS as a way to help them maintain anesthesia, right? So the 3 phases of anesthesia being induction, maintenance, and emergence. So maintenance, the longest period of time during most general anesthetics, is where most of us think of using the device because it can be a little boring monitoring someone during the maintenance phase of anesthesia. We get things started at the beginning, there's a lot of excitement, and then you get into the maintenance phase where really your job is to try and keep everything the same while the surgery is ongoing. In a 3 or 4 hour procedure, you may have 3.5 hours of time where your whole goal is to keep the patient at that same level of hypnosis, even though there will be changes in surgical stimulation depending on what they're doing. Initial incision is very stimulating, and then there's a long period of time of boring dissection, and then they finally get to the part where they're going to start applying vascular clamps or manipulating the gut and causing changes in hemodynamic parameters because they're losing blood, or the patient is starting to third space and you're having to adjust fluids or pressure administration. And then you start messing with your anesthetic to try and compensate for those hemodynamic changes. That's where most of us think of the BIS as adding extra value. So, traditionally we would use just hemodynamic parameters and physical signs of the patient to try and decide if they were light or appropriately anesthetized or too deeply anesthetized. So if you look at things like lacrimation, the patient's tearing or sweating, tachycardia, hypertension, all of those things are signs that the patient may be light. And then you have this additional piece of information with the BIS number, essentially giving you an idea, is my clinical impression of the patient appropriate? Am I on the right track? I have this other thing to confirm. Conversely, it can also be used as a sort of an early warning. As I mentioned, sometimes during a 3-hour procedure, everything's sort of the same. We're getting a little distracted or bored, but you happen to notice that your BIS number has been trending up or trending down, or that there's a sudden change in it, and it forces you to now reevaluate the situation. Why did I just suddenly have my BIS jump up or start going down? Did I do something, to correlate with that? So it's a helpful way to keep us engaged in the anesthetic and to give you an additional piece of information beyond our traditional parameters. So most of us are really pretty comfortable with managing the maintenance phase and with using the BIS as a helpful monitor during that time. But I think it's kind of overlooked that you can also, get a lot of value out of it during induction. So during the induction phase of anesthesia, we take a wide awake person who may have gotten some light sedation coming into the room and might not have a BIS of 100, a little bit of Versed preoperatively while we put the monitors on. And then your first numbers are in the 80s or 90 because they're already a little bit relaxed. Or conversely, you have somebody who's super excited because they, are a trauma victim who hasn't gotten any drugs, and we're just throwing them onto the table and applying our monitors as fast as we can. Their BIS may be through the roof because they have, broken bones and are in a lot of pain. So knowing where you're starting with the patient before you start giving your induction agents can be really helpful. And then if you have a situation where you're trying to limit the amount of induction agent because of hemodynamic concerns, the patient's hypovolemic from blood loss, or it's an elderly ill patient, somebody with serious cardiovascular disease, aortic stenosis, other conditions that we're really worried about overdoing it with the anesthetic induction agents, you can use the BIS as an additional monitor to help you titrate without overdoing it. So if I have the patient and I'm thinking I'm going to give them a quarter or a third of the amount of induction dose that I would give them ordinarily in this new clinical situation where they're acutely ill, the BIS can reassure me that I'm giving them enough. So I am, thinking that I can get away with now performing laryngoscopy and placing the breathing tube and not having them have awareness of that, or having them have an exaggerated hemodynamic response because I have them too light. So I think it is really helpful in those situations to put the BIS on early. So for heart surgery patients in my hospital, we routinely apply the BIS pre-induction, and it is reassuring when we're going to try to get away with using a little less anesthetic agent than usual. On the other hand, there are times when we underdo it, and then you're going to go perform laryngoscopy. The blood pressure is going to go through the roof. So I think having the BIS there as an additional piece of information really does help you avoid either under or overdoing it with your induction agent. So when you get to the emergence phase, a lot of times at the end of the surgery, there's this prolonged period of time where we're trying to titrate our maintenance agents off, and the surgical stimulus is reducing a great deal. So you're now trying to make your emergence be as quick as possible without the risk of the patient starting to buck or kick while you're putting your last few sutures in the skin. So it can be very helpful to try and achieve that goal of keeping the BIS, just under 60 while you're lightening the patient up, reducing your inhalational agent or your, intravenous anesthetic hip, so that you can get the patient as light as possible without having them, suddenly move or have much risk of awareness towards the end there. I mean, sometimes there are cases where it feels like the splinting and wound dressing takes as long as the operation, right? So there's this long period of time at the end of many cases where the patient still needs to remain still, but there's very little surgical stimulation while they're, doing whatever dressing or splinting. And then we, can really have that patient just skating along at just sedated enough so that we all look really good and feel really good about having that really quick emergence without having it be premature. By using that, we also probably shorten their PACU stay and, reduce some of the other side effects of giving more agent than is necessary. So prolonged emergence in the operating room, generally speaking, leads to prolonged PACU stays and postoperative delirium risk.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.